vasculitis. Today we will discuss the full about vasculitis outcome and management in dialysis patients.
Thank you, Professor and faculty. It's a great honor to be here. It's quite rare condition we're talking about vasculitis and patients who survive vasculitis and go on to develop decision failure is even more rare, so the literature is rather limited. And I've got to sit with us, and I do apologize. I'm trying to ask us. So these are some things we're going to cover in this session: is vasculitis and the kidney involvement, factors predicting end-stage failure, and ANCA-associated vasculitis. The last focus is going to be actually on ANCA-associated vasculitis. Whilst I was doing it, I kind of realized that probably HC-associated vasculitis is far more common in Egypt compared to ANCA-vasculitis. We don't see much HC vasculitis. In my experience, is limited to one patient, so I'll rather not talk about that. We'll focus on ANCA-vasculitis. Look at the outcomes, look at the immunosuppression in dialysis patients, and probably what's more relevant is the transplantation in these patients. I don't think we need to go into the details, but we know that ANCA-vasculitis has got a wide spectrum of the organ involvement, and if you see the top triangle, it's ANCA-associated extrarenal vasculitis, so there is probably around 15 to 20% of the patients on the other end where kidneys are not involved. These are the people who have lung involvement, ENT involvement, possibly neurological involvement, but their kidneys are preserved. And at the other end of the spectrum, we've got about another 10 to 15% patients where only kidneys are involved, and some people would classify them as renal limited vasculitis. And there's a large number of patients in between where you would see both kidneys and extrarenal vasculitis. This is slightly old story. About 10 years ago, a group from Chapel Hill, Charles Jeanette and Ron Clark, that was the leading experts in the vasculitis. They went to 3,000 kidney biopsies, and they focused only on those who had presenting glomerulonephritis. And they divided it into those who had any presence, and you probably know that occasionally we see presence even in conditions like membranous glomerulonephritis. Some IGS probably have a presenting involvement. And then there are immune complex and GBM causing, which obviously are the most common conditions associated with present formation in the kidneys. And then they divided into those who had any presence, those who had more than 50% presence, and presence of vasculitis in the biopsy. And obviously, as one would anticipate, that those with immune complex presenting glomerulonephritis, you do find presence in around half the number of patients. But when you put the cutoff of at least 50% of the glomeruli have a kidney presenting involvement, the numbers drop down to less than a third, and presence of vasculitis is even far rare in this group. Anti-GBM figures are there in front of you, and probably the most common or the strongest disease where you got presenting glomerulonephritis is causing glomerulonephritis, and 90% of these patients will have circulating ANCA, or what we call as ANCA-associated vasculitis. And certainly the presence of vasculitis in the biopsy is the predominant feature in these group of patients. So these are the ones which we will focus with. When they divided these patients, depending on the age group, that gives a clear idea. Those with immune complex deposits, or the first group, where you would see it's far more common in those who are under 40 years of age, and that's predominantly the large number of patients you would see immune complex associated presenting glomerulonephritis. And as they get older, particularly those about 65, these numbers drop down rapidly, and immune complex presenting glomerulonephritis is quite rare in elderly patients. Anti-GBM, there is a pretty much even split, but there is some importance to those with the younger, and again, large number of patients are under the age of 40. But if you look at causing glomerulonephritis, it clearly goes to the relationship. There is probably slight high numbers in 10 to 19 years younger patients, but in our own epidemiological studies, we've seen the steady linear relationship. As one gets older, the incidence of ANCA-vasculitis goes up significantly, and a large number of patients are more than 65 years old. And this does have some relevance as to what happens to their kidney functions when they develop glomerulonephritis. the epidemiological studies to see renal involvement are slightly difficult to interpret because a lot of these people, if they have just pure lung involvement, they will be treated by respiratory physicians, and if they have ENT involvement, there are some ENT surgeons who treat these patients, some rheumatologists treat them, some nephrologists treat them, and to get the exact figures becomes a bit difficult. But I think probably this one of the studies, the French FFS study of 5-factor study published in 2009, they looked at about 1,100 vasculitis patients. Now, one thing I wanted to make clear that polyarthritis nodosa is far more common in France compared to the rest of the Europe. And same goes with the Church trials. So I have kind of focused more on the MP or microscopic polyangiitis and vagus radiculitis. Nowadays we call it the GPA, general polyangiitis. So if we focus on those two columns of MP and WG, and if you look at the renal insufficiency or kidney or urological symptoms, you would find around 75% of the MPA patients will have kidney involvement, and 68% of the venous radiculitis patients will have kidney involvement. So if you go by these epidemiological studies and some other studies, the kidney involvement in these patients, about 75 to 80% of the vasculitis patients will have their kidneys involved at some stage during the course of the vasculitis. If there's anything that's not clear, you can't too fast this stop. So I tried to look a little bit focused on this part of the country, and strictly speaking, we're in Africa and the Middle East, but that was the only paper I could find. I guess geographically and genetically, Egypt is probably more linked to the Middle East rather than the African subcontinent, and there are hardly any epidemiological studies from Africa. But this was an interesting study done by Dr. Al-Rashid and his group. They published, and the analysis was done by Richard Watson, DGI Scott. These two rheumatologists from UK have done a lot of epidemiological work in vasculitis, and they make an interesting comment that there's been a high incidence of vasculitis from Kuwait, and the incidence was for polyarthritis, but the 16 cases per million is rather high, and NP or microscopic polyangiitis 24 cases, which is again high. In our own experience, the incidence is about 15 to 20 cases per million populations. It's quite a high incidence, has been reported from Kuwait. They do make the reference that some of these patients probably do come from the neighboring countries like Indian subcontinent, Philippines, Indonesia, and there is a reference to Egypt in that paper. So we know that kidneys are involved, and why is it important to know that the kidneys are involved in the vasculitis? There are two things that decide what happens to the vasculitis patients' long-term survival, and those are highlighted there. One is age, and second is a CKD stage 5. So this was the meta-analysis done by Oliver Crossman's group. This is a lot of these studies have come from UVAS, the European Vasculitis Study Group. They have set up a lot of vasculitis trial, and this paper was published in Lancet in 2011. They looked at 535 vasculitis patients who were recruited for 4 different vasculitis trials, and all that they looked at is their long-term survival. And when they did the multivariable analysis, the 2 factors that stood out, which decided the survival, was age. And about 60 years of age, every 5 years improvement was associated with progressive increased mortality in these patients. And not surprisingly, with the CKD stage 5, these are the only 2 factors. No other factors like the VVAS scoring, which is the vasculitis severity index, the kind of factor of clinical diagnosis didn't really stand. And that doesn't surprise us that CKD 5 is bad, vasculitis or otherwise. So, what predisposes now, although about 20 cases per million are reported with vasculitis, and 80% of these patients will have kidneys involvement, we probably don't see that many patients in our dialysis program with diagnosis of vasculitis. I don't know what the local experience is like. Do you have many patients with vasculitis on dialysis?
No.
Yeah, I think we've got similar, I think I've probably got 4 or 5 that I can think of in our program of around 400 dialysis patients. So these figures, for some reason, don't tally. People have done statistical analysis. If you take the incidence of 20 cases per million, and the end-stage renal failure reported is thought to be 25%, that should give you 5 cases per million population. which we don't see in our own group.
No, I see about 5 cases in my life. Okay, 2 of them were vaginal keratinosis, and the third with skin infection, and the patient started plasmapheresis and the patient. Yeah?
in محله
لا not an institute for health and research. Okay? And actually the patient died before become a maintenance dialysis.
I think that's true.
Especially from serial manifestation. Actually, so I'd like to talk about if we can plan for a serial manifestation. Actually, with the patient, we love this kidney and they become a maintenance in dialysis. How we plan to manage him on dialysis regarding immune suppression or
this is a discussion.
And I think there's very little information about that. So there are a few groups which have looked as to what decides what are there any predicting factors which would help us to know if the patient is likely to develop menstruation failure. I think it would probably fair to say that active vasculitis is predominantly, this is a Caucasian people, and there's a lot more vasculitis in Northern Europe. As we go further down, it's probably there's more of the MPA, but again the incidence goes down. I did a criminological study in London, and we had a third of the patients were Caucasian, third were Asian, and third were black. And I could find a single black patient with vasculitis and only 2 Asian with the vasculitis. Throughout everyone else was Caucasian. So that means genetically Caucasians are more predisposed, so probably that's why the representation in this country obviously would be a lot less. Going back to this study with so reflex was one of the vasculitis studies where they randomized patients either to get a plasma exchange and alpha-prednisone. The study was published, it showed plasma exchange was good for these people, but then later post-analysis, a different study, they looked at the biopsies and biopsies were scored by this pathologist, and when they did a multivariate analysis for what were the predicting factors to develop menstruation failure in these patients, they came out with some clinical criteria like the entry serum creatinine. So those who had a serum creatinine more than 500, which in SI is around 7 milligrams per deciliter. And the age, obviously advancing age, was associated with increased risk of developing menstruation failure in these patients. And this is at 12 months, so these are people who have developed menstruation failure at the end of 12 months of the recruitment period. And then they came out with some interesting histological factors, the number of presents, chronic damage, arteriosclerosis at the entry was an interesting factor that they came up with, percentage of normal glomeruli. So when we looked at the GFR at 12 months, it's probably difficult to see, but otherwise you can see the corrected GFR 12, that's what it says. And the first graph is the age, and as the age advances, the GFR goes down slowly. And as we've seen, acrovasculitis predominantly affects old people. One would expect a lot of these people would develop menstruation failure if they survive long enough. The second graph in the middle is the percentage of normal glomeruli, and as again one would anticipate as the number of normal glomeruli increase, the risk of developing menstruation failure goes down. And in the last group, we looked at the arteriosclerosis, and it was simple scoring, and they had arteriosclerosis and no arteriosclerosis. So they got a 0 point if there was no arteriosclerosis, so 1 point if they did have arteriosclerosis. And the arteriosclerosis at the time of diagnosis, obviously the biopsies were done at the time of diagnosis, we decided these patients developed menstruation failure. Interestingly, they didn't find any correlation in arteriosclerosis and age. So even some younger people with arteriosclerosis, or young people had arteriosclerosis, and some older people didn't have arteriosclerosis. So these are some of the factors that helps us to decide if patients will develop menstruation failure. But probably far more easy and simple is this paper published again by the US group, and this Burden was the first author. So a lot of people call it the Burden classification. And what they did was they divided the vasculitis biopsy findings into 4 groups, starting with the number of sclerosed glomeruli. So if 50% glomeruli were sclerosed, they fell into the group of the last group as a sclerotic. Then if the 50% glomeruli were not sclerosed, then they did the next step. They looked at the glomeruli. If they were normal, then they called them as a focal vasculitis. They just had maybe 20% glomeruli were affected with necrotizing glomerulitis. If 50% glomeruli were not sclerosed but they were not normal, that means they have some sort of presenting involvement. and then we looked at the number of the presents. So if the presents were 50%, then they were called as presenting glomerulonephritis. And there were few patients where maybe 70% glomerular were not normal, but only 30% were sclerotic and only maybe 40% had presence. So they became the mixed one. And those histological criteria, when we looked at and they followed these patients just for the period of 12 months, and you can see those who had focal involvement as one would anticipate, none of those patients, with 100 patients included in this study, none of those patients had an incision of failure in 12 months period. Those who had a presenting glomerulonephritis, about 15%, about 15-20% did develop incision failure by the end of 12 months period. The numbers go up with the mix, and as sclerotic glomerulitis, steady spread of chronic damage, about 65-70% of the patients had developed incision failure within 12 months of period. And when we look at the GFR, which is presented below, the focal obviously had a well-preserved GFR of 56.4 mils per minute, and their GFR at the end of 12 months was 63, so they gained about 7-8 mils of GFR. Presenting obviously is the most severe form of vasculitis. Their GFR was 11, they were on the brink of dialysis, but they had maximum improvement in their renal function with about 21 mils of GFR, and their GFR at the 12 months was 32.8. Those with the mix had a modest improvement from 15 to 24.5, and those with the sclerotic had the least improvement from 10.8 to 6. Not surprisingly, these patients went on to develop incision failure. So what happens to those patients who survive and live life with incision failure with vasculitis? And again, we know the numbers are small, certainly in this part, but I think in Europe the numbers are pretty large, and this is a large study that comes from the France registry. RER is a renal innovation network. Sorry, I can't remember what it stands for. So this was a group that was set up in 2001, and they started collecting data on all the patients who started chronic dialysis program. And they published their 10-year findings in 2011. So overall, 425 patients in France were on chronic dialysis. So these are not the patients who needed 1 or 2 sessions of dialysis with acute vasculitis. These are the patients who had, at the end of 90 days period since their diagnosis, were on dialysis, and they were called to be chronic dialysis patient by definition. So 425 patients were identified in a period of 10 years period. And they compared their outcomes to approximately double 794 gender-matched non-vasculitis patients. Median survival, median follow-up was 23 months, just under 2 years. And again, as mentioned, in Northern Europe, you see more granulomatous with polyangiitis, the weakness of vasculitis. As you go further south, you see more microscopic polyangiitis. And the survival, they excluded the patients who were transplanted, and 19 patients did recover renal function, and this recovery went on between 3 months to 11 months. So some patients were on dialysis as long as 11 months since their diagnosis, and then recovered renal function. So they excluded those patients, and when they looked at the remaining 370 odd patients, the median survival was 5.3 years. This is 2 years follow-up period, and then the median follow-up is just under 2 years. It's the same as the age match control. But when they looked at the mortality, so the top line is the green line, which is for the anti-vasculitis patients on chronic dialysis, and the green line, the red line is non-vasculitis control. You can see there are no differences. The survival of these patients, if they develop incision failure, is the same as non-vasculitis patients. But when they look at the mortality, the two things that makes a big difference, obviously cardiovascular, we're aware is the leading cause of death, whether it's due to vasculitis or non-vasculitis. But those who had vasculitis, 20% patients died due to infective complications, compared to only 8% infective deaths in the non-vasculitis cohort. And the malignancies were only 4% in vasculitis cohort, and those 50% in non-vasculitis cohort. So obviously these people carry their immunosuppression burden in their dialysis period, and that is a relevant point when we have to continue treatment for these patients when they are on dialysis. So just a little overview about the anti-vasculitis. We have moved on. We have steroids in 1948. which had a dismal effect on the survival. The average survival of untreated generalized vasculitis was 5 months. With the addition of steroids, I think in 7 months, the steroid had virtually no impact on the survival of the vasculitis patient. Then in 16, we had cyclosporine and methotrexate as heparin. Plasma exchange became available in 1976. MMF and CNI in the 80s and 90s, and biologists like TNF blocker and more distributors in our similar agents are in the late 90s, really. And the treatment depends on the severity of the vasculitis. So if it's the organ, non-life-threatening organs, if it's just a ENT-related disease, you would probably want to treat them differently compared to with the kidney wall or non-hemorrhage. And if it's a severe disease, obviously you treat them more aggressively. And that kind of summarizes the treatment of vasculitis. So if it's a localized disease, just a nasal disease, or the NORAM trial, which looked at modest renal involvement with creatinine less than 2 milligrams per deciliter, they were treated with methotrexate. They got more relapses, but methotrexate and glucocorticoids would be treatment for milder forms of vasculitis, both for reduction and for maintenance, and azathioprine would be replaced for maintenance. For early systemic vasculitis, so those who have kidney involvement or lung involvement, more than one organ system, they probably do need cyclosporine. Some people have tried using methotrexate, but we see more relapses in these patients. But once they have achieved remission, the maintenance can be done either with methotrexate, azathioprine, MMF, with glucocorticoids. Lenalidomide has been used in small group patients. It's difficult to monitor causes of leukemia. Those with generalized vasculitis, so the multiple organs are involved, obviously needs standard cyclosporine and steroid-based treatment. Maintenance is safe. Those with severe, so those with lung hemorrhage or dialysis and renal failure, current guidelines say we need to have plasma exchange for rapid removal of these antibodies in these patients. And those who are refractory, so in spite of the standard treatment, don't respond to those treatments. We've got a variety of different drugs available now with infliximab, 15-DHT, which I think Japanese have used it a lot. There's a small size from Cambridge, it's an injectable drug to be given every weekly. I don't think many people are familiar with that. It's not widely available. It was used a long time ago, but now infliximab, we don't use these drugs. Ideally, it is useful if they have a concomitant infection because it helps both infection and vasculitis. So, we know that certain number of patients will end up on dialysis with vasculitis, and the question is how to treat them. This is not about the vasculitis patient, this is the US data, and this is depending on the different insurance providers, Medicare, market scan, or free. We looked at hospitalization for infections, and the first column is that those who don't have CKD, and the next column, this group, is those who have CKD. And the moment patient has got a chronic kidney disease, the risk of hospitalization for infection goes up. And they subsequently further divided CKD into CKD 1 and 2, CKD 3, CKD 4 and 5. And as the CKD stage goes up, the risk of infection goes up. So these are not vasculitis patients. But just by having the CKD or progressive CKD, the risk of infection goes up. And this is the mortality from the USRDS, which is the largest dialysis database in the US. And as you can see, the all-cause mortality is highest in the first 90 days, and then it comes down. This is equivalent data that are presented. Leading cause immense cardiovascular, we know that. But the second leading cause is infections. So it's known that dialysis patients, the second leading cause of death is infections. And when you have pancreavasculitis and immunosuppression, which we've seen from the French registry data, that they get the effective mortality is high in this group. So we have to bear this in mind that infection risk is already high in dialysis patients. And these are variety of the reasons. This is in general population. A third of our patients are diabetic. They have the risk of infections. Most of them have immunosuppression by virtue of duration. Some of the activities with immunosuppression either due to rheumatoid or vasculitis or lupus, and they carry the burden of immunosuppression through their dialysis period. A lot of these patients are elderly, so they have comorbidities. They probably have chronic lung disease, and their lungs are damaged, and they're more prone to develop respiratory infections. Some of them have got congestive heart failure, so they once get congestion, again they develop respiratory infections. Peripheral vasculitis is common in these people with diabetes, hypertension, and vasculitis is very common in these groups. So again, they're more prone to develop soft tissue infections and osteomyelitis. Malnutrition is strongly associated with dialysis. Low albumin acidosis affects the neutrophil function, and these people have acidosis with greater than 3 times a week. So there's a variety of reasons why these people develop nutrient suppression. We disturb the development barrier at about between dialysis line or feeding cancers. Even if they go to fistula, we need it 150 times a year. So we are causing a lot of development barrier disruptions. There's a lot of evidence coming in the recent years that iron increases the risk of infections. We depend on the iron for survival. Microbes depend on the iron for survival. So we give iron, microbes thrive, and the infection risk goes up, and we use a lot of iron in these patients. These people are in hospital all the time. Some of them are 3 times a week in the hospital, so they share the infections from their fellow patients. So dialysis patients have all the risk factors for infection, and vasculitis patients endemic dialysis have all of the above. Plus their immune suppression, and plus they have got organ damage, their sinuses are damaged, they are more prone to have respiratory infections and lung infections. So these are the things that we have to remember. But the question is, do we really need to treat these vasculitis patients once they're on dialysis? And that is where I think the numbers are small, but this is the only interesting study I found from Germany. They looked at once the patients are established on dialysis, what happens to their vasculitis. It's a rather small study published in 1998, 35 patients who had diagnosis of vasculitis who were on long-term dialysis. That was a follow-up period of 43 months. 6 patients died, and again, as one would anticipate, 3 were due to treatment toxicity. But for remaining patients, 37 patients, in a relatively short period of time, 43 months, there were 29 relapses. So even if their kidneys are damaged, these people do get relapses, and their vasculitis does need treatment, even if they're on dialysis. So we are in this difficult situation that these people are prone to develop infections. At the same time, they are at risk of developing relapses, and that proves a challenge. And the relapse rate was 0.24 relapses per patient here. Interestingly, 2 relapses occurred while they were on immunosuppressive treatment with steroids, and some of them were even on cyclophosphamide. But some of the relapses do occur when they are not on immunosuppressive treatment, and then you can see the more interesting data. But in this small group, they were able to achieve remission quite successfully in large number of patients. So while treating these vasculitis patients with end-stage failure, we have to look at some of the pharmacokinetic factors that may be relevant while treating these patients. And this is the data from the renal drug handbook. What happens to drug handling that we commonly use in vasculitis setup once they're on dialysis? Cyclophosphamide is the most common drug. And numbers are not that impressive, but they say that the GFR is less than 10. So there are these patients we're talking about. We need to reduce it maybe 50%, as well as 50% cyclophosphamide dose. It is dialyzed, so we need to have a bit of a gap between cyclophosphamide, and they said the dosing of cyclophosphamide in the next dialysis, there needs to be at least 12 hours duration. Microphenolate, we're using more of it, and there are 2 sorts of microphenolate mofetil and microphenolate sodium or mycotic. And the normal renal function, the dose is about 3 grams or up to 3 grams per day. But when the GFR goes down, microphenolate sodium or mycotic dose doesn't get changed. You can use same dose of mycotic according to the renal handling of the microphenolate sodium salt. But microphenolate mofetil does tend to accumulate, and there is a reduction of 30%. So we can use maximum 2 grams compared to 3 grams which is normal renal function. As I mentioned, microphenolate sodium dose doesn't change. None of the salts are dialyzed, so you can use normal dosing for these patients. Next is rituximab. It's quite a new drug, and being a new drug, there's very little information available, and as usual, the manufacturers hide the standard precaution to use with caution, no matter whether GFR is 20 to 50 or GFR less than 10. We have used rituximab in few dialysis patients quite safely. Numbers are small, so I can't say that the use with the caution is the right thing to do. It is not dialyzed. We can pretty much dialyzed patients immediately after rituximab without worry of removing the drug on dialysis. Azathioprine, I think a large number of our patients, when they are on institutional failure, probably will be on azathioprine. And that's probably worth remembering that the dose does need to go down, maybe up to 50% when they're on dialysis, and probably 75% of the GFRs 10 to 20 mils per day. Interestingly, the drug is dialyzed, so we have to give normal dose when they're on dialysis, so we don't need any reduction if they're on dialysis, but if they're CKD5 on dialysis, they need a reduction in the dose of azathioprine. Methotrexate, we know is contraindicated in GFR is less than 10, and for most of us, we probably not use when GFR is less than 20. If you have to use, we need to have a substantial reduction in the dose of the methotrexate. As it's contraindicated, we don't really, dialysis information doesn't really become useful, but they do say it is removed, so we probably can use 50% dose after the dialysis, but I don't think anyone should be great at using methotrexate in dialysis patients. So these are some of the things that we need to bear in mind if we have to treat the dialysis patient who have increases of infection, where at the same time are at risk of developing vasculitis while they're on dialysis. So moving on to the next thing is transplantation. Transplantation is good for everybody, and vasculitis is not an exception. And the studies show that those who are waiting on the transplant list compared to those who are lucky enough to get transplanted, and when they follow this patient, there is a 60% reduction in the mortality if they are transplanted. So transplant definitely is good. Interestingly, transplantation also reduces the risk of relapse. So the average risk of relapse in the vasculitis patient, if they're not on dialysis, is about 10% per year. That goes down, if you look at the previous study from Modern House, it's around 0.25 cases per year. And if they're transplanted, the risk goes down further to 0.05. So transplantation not only reduces the mortality, but it also reduces the risk of relapsing these patients. So, what is the survival and what is the outcome of the transplantations with the vasculitis? And I think this is probably one of the largest studies from Australia and New Zealand registry data. So, it's about 14 years data that they looked at 37,000 dialysis patients, of which 450 patients with antivasculitis as a cause of kidney failure. Again, as you go, obviously, Australia, there are Northern European ancestry, but there probably are environmental factors. So by being in Southern Hemisphere, you can see the split up between NP and GP is equal. 228 patients with NPA, maximally polynucleosis, and 220 with the GPA. It's about even split in these patients, and a large number of patients. So 46 antivasculitis patients were transplanted out of 450 patients. And when they looked at the 10 years of survival, it was poor in those who had microscopic polynucleosis, but it was comparable in those with microscopic polynucleosis and non-vasculitis patients. The recurrence rate of vasculitis was only 2% in these patients. The interesting finding that they came out with the age at the transplant was much higher if they had vasculitis as a cause of diagnosis. So that was 60 and 61. For vasculitis patient compared to 58. It doesn't sound that big, but when you have got 37,000 dialysis patients, the results sound significant. Which kind of tells you that this is disease of elderly patients, and they get vasculitis, they are probably more than 60 years old. And those who are probably just from the brink of 60 to 65 would be considered fit enough to have a transplant. So this was their output data when we looked at, and the graph on that side is the overall survival of these patients. And if you look at first 5-6 years, the lines overlap. So the middle line is the reference line for non-vasculitis patients. The dotted line on the top is those with the GPA, and the solid line at the bottom is those with the microscopic polynucleosis. And after 6 or 7 years, there's a clear signal that those with microscopic polynucleosis do badly. It's just clear there wasn't significantly, the p-values are there in the top of the table. But there's a clear signal of these we could probably follow with the long enough. Then this is long enough follow. But overall survival, there is some benefit for the GPA patients with the transplant. But when they look at the graft survival, there's a clear difference. The top dotted line is those with the GPA. The reference line in between is the non-vasculitis patients, and the solid line at the bottom is those with the NPA. and those with hypersensitive polyneuropathy have much poor survival in this cohort. But still, compared to their transplant waiting list counterpart, their survival is better. So transplant is still best modality of treatment in these patients. This was another study from Dutch transplant from the vasculitis, they call it the Dutch study. So they looked at 113 patients with vasculitis. The Australian New Zealand registered 49 patients. So this is a much larger number of patients, 113 patients. All that they did was focus on the first transplant. So if they had a second or third transplant, the outcomes were excluded from these patients. 5-year follow-up, 19 grafts were lost, 4 were due to recurrence of the vasculitis. So 113 transplant, 4 graft process due to transplant recurrence is quite acceptable for recurrence of the primary disease. There were 14 relapses, and as you can see that there were a number of relapses were extrarenal, so extrarenal figures are higher compared to the renal relapses, which is only 2.8% and the renal is 3.6%. And those who had a renal relapse, not surprisingly, had increased risk of graft loss, 4 out of 11. So, when we're looking at the transplant patients, I probably should talk to this slide later. This slide. So, this was a data published by Mark Will, and what he did was summarize all the transplant patients with vasculitis who were vasculitis patients who were transplanted, and we looked at their outcomes. And as you can see, some studies are as old as 1965. While other studies are more recent, and obviously the recent studies will have improved outcomes. Some studies had much smaller numbers, like 9, but the Macklin study of Macklin from the UNC Chapel Hill pulled data was around, I think, 25 odd years, 127 patients. And in the bracket, the relapse rate is the relapse rate per patient year, and except for probably one study of 0.1, a small study, 20 patients, most of the figures are 0.01 and 0.08. And when they take the subtotal of around 700 patients, the risk of relapse in transplantation is 0.04. That's what it's transplant. So risk of relapse is quite low in these patients compared to their renal failure counterpart, and much lower compared to their non-dialysis counterpart. Obviously, these people are on immunosuppression due to transplant, and that reduces the risk of relapses. And that can bring back to this the strategies as to how to reduce the infections in these patients. So again, transplant patients also have increased risk of infections, and these are some of things to remember is to reduce the glucocorticoid exposure, monitor the white cell count, particularly the lymphocyte count. And cytophosphamide predominantly affects the lymphocyte count. There are Canadian studies and our own studies we have looked at, and the neutropenia is extremely rare in these patients. One rate is profound lymphopenia. And one thing that predicts the risk of infection is the degree of lymphopenia. The lymphocyte count is less than 400. Absolute lymphocyte count, the risk of the vascular infection is significantly high compared to those with the lymphocyte count of 1,000. I think those are things that we need to look at. IgG, again, there are some studies which have showed if the IgG levels are less than 7, the risk of infection goes significantly high in these patients. So we need to tailor our immunosuppression based on their lymphocyte count, based on their hemoglobin G levels. Vaccination obviously is the easiest and best way to reduce the infections for things that we need to manage. Appropriate use of antibiotics, antiviral prophylaxis, BCG prophylaxis, antifungal prophylaxis, and obviously patient education and probably our healthcare colleagues' education. So those in primary care, general practitioner needs to know that these people need aggressive treatment of the infections in the early period. So, to summarize, vasculitis is the commonest cause of rapidly progressive glomerulonephritis. Renal involvement is seen in 75 to 80% of the patients. Up to 2% of the patients with renal failure will have diagnosis of vasculitis. Figures vary depending on which part of the world they live. Survival is same as non-vasculitis patients, but the mortality due to infection in these patients is much higher, 20% compared to 8% of the non-vasculitis patients. And we should follow some strategies to reduce the risk of infection. Relapses can occur even when they have end-stage failure, and some of them will need immunosuppressive treatment, and various factors that we discussed in remember while continuing the suppression in these patients. and the last phase transplant is the best form of RRT in these patients and is associated with very slight risk of relapse and recurrence of the disease. So that's what I would like. Thank you.
Introduction to the game is on the concession.
Quite rare, so I probably my experience with the X is so little that.
Actually, here we most of the patient vasculitis, small vessel vasculitis is the main complexity. Actually, more than the small vessel vasculitis, like because actually Egypt is actually endemic country. So usually,
I think you cannot say this correctly because we don't have statistics. Number one, number two, we don't request the NCAP for the many cases. So you cannot extrapolate this statement.
Actually, most of the biopsies that done in our center, the first center that will work in National Institute Hospital, actually most of the cases of vasculitis where is cryo, meaning doesn't cryo or RC, and actually usually started by using dialysis and cyclophosphamide, and we postpone the treatment with alpha interferon for about 4 months post-treatment.
What are the main things now for the population?
Actually, the number of clinicians is too low. About the actual number of them about 700,000 population, and most of them are not from the Kuwait itself. So we can't estimate the actual statistic for that. Yeah.
Thank you very much for the. Thank you very much for that interesting point. For the Kuwait point, it's really interesting that we can't make comments about populations when there is a big number of immigrants. And this is one of the important things when we talk about reflection of the population. But when we talk about Egypt, the majority of people are native Egyptian people. While when we talk about the Gulf region, big percentage of people coming from different backgrounds, and then they will reflect certain tendencies and diseases. So I think we should take this study with the cautiousness.
Regarding Oxymab use, your experience, you mentioned that you want to use infrequently in dialysis.
Yeah, we've had about 3 or 4 patients who use dialysis, and they have tolerated quite well.
Do you use a standard dose?
We use random variation
So 1 gram twice every week.
1 gram to weeks about.
Actually, regarding the MMF versus cyclophosphamide treatment of active vasculitis, proven by biopsy if there is a plasma vasculitis biopsy, it will equal or it's much better to start with cyclophosphamide.
The 5% is much better. Even for the maintenance, the ACE pattern and MMF, when they compare, ACE pattern is superior. So there are still trials in progress about MMF for induction. For the relapse prevention, it's interesting to make the International Journal Institute for memory science study, and it's maps far superior than ACE pattern for population of relapses. So maybe the standard policy.
And actually, I want to talk about something in the recent trials. Actually, what we are feeling here in the emerging countries, there is something drug being. What will happen? The drug will be after about 3 months. A lot of papers we don't know about the power of papers and the drugs that we use in all the treatment of all drugs disease, like rituximab. Yeah, rituximab in NCD, rituximab in MN, rituximab in vasculitis, rituximab in whatever. It's called both. We feel that the drugs usually push. Actually, the basic data about vasculitis is usually cyclophosphamide. After that, we talk about MMF, like all diseases that will be used for MMF. After that, we are using what? Rituximab that will be used.
Certainly not the first line drug being used skin. We use it as a personal infection skin, like it's a young woman with vasculitis, you know, to expose.
Because I think because it's 37, so the infection rate with is lower, quite lower than cyclosporin. The main limitation for velocity of
Price.
But through the air, it's effective. It's evidence in the studies it's okay to use. Because it targets B-cell, targets antibodies that have mechanistic in the disease.
The notification came in that we report with
Yes.
that's why it's get second line. It's very dangerous.
Yeah.
And another warning is the flex speed. So we shouldn't use the solar flex speed ratios. If it's really needed, we should treat your flex speed first.
Basically, we need we have to all these things. We do them with these takers. We warn them about fear. I think going back to the data, there are about 65 cases reported worldwide with about 2 million estimated doses prescribed. And I think when they went back to those 65 cases, they all had a very good lupus. And they had 21 years anti-vasculitis elements, primary and that's probably the last straw that gave the fear. When you look at the lymphoma data, when they just got this map, so none of them have the PFS. But when it comes to this, obviously, fatal complications are being managed.
Put in mind that you can detect this about 3 years.
No, we can't get it yet.
It's a little.
Once it's done,
Thank you very much.